Welcome, everyone. It's a beautiful Friday. I'm calling in from Toronto. I hope that it's beautiful where you are too. I'm Dr. Tara Kieran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. We're so delighted we continue to bring you these sessions together with the Ontario College of Family Physicians, and I'm going to turn it over to their president, Mekalai Kumanan, to introduce the session. Mekalai?
Thanks, Tara. Good morning, everyone. Welcome. Thanks for joining us. We've got a couple of great speakers and topics lined up, and I just wanted to thank our speakers for being here with us today. And a reminder that this is a Main Pro accredited session, and you'll receive details by email. Next slide. Just moving on to our land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite us all to reflect on the territories we are calling in from as we commit to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Chinantan peoples. Next slide.
I've been reflecting a lot on how we can have a more inclusive, culturally safe healthcare system because of some conversations we've been having through our care, including with people from First Nation, Inuit, and Métis communities across Canada. And I think they shared that there are still many experiences of racism and discrimination, but they've also shared the strength in their own communities and the models of care that they bring that we should be honoring and trying to integrate into our work. So if you want to read more about what we've heard from our community roundtables, please just go to our website there. Next slide. I'm delighted that we're continuing to bring you these sessions, and of course, check out our website for past sessions, as well as our current session recording, as well as the resources and slides will be posted following the session. Big shout out to our planning committee team who helps to organize these. Next slide. I'm delighted that we've got these wonderful guests today. Next slide, and I'm going to turn it over to Dr. Kieran Quinn to introduce himself.
Good morning, everyone. Really a pleasure to be here again. I gave this talk about a year ago, and thank you for having me back. I'm a general internist and palliative care physician at Sinai in Toronto. And in terms of long COVID work, I serve as the site lead for the RECLAIM trial, which I'll talk about briefly today. I'm one of the co-chairs of the National Guideline Committee, where we're developing guidelines for long COVID, as well as one of the co-chairs for Long COVID Web, our national research network. My disclosures are there, and thank you for having me again. It's a pleasure to be here.
Thanks, Kieran. Mike Kolber?
Hi, good morning, everyone. Good morning from Alberta, where it's a few hours earlier, but happy to be here. Mike Kolber, professor at the University of Alberta, clinically in Peace River in northern Alberta. And my disclosures, I do get honorariums occasionally. All from not-for-profits. I have a U of A spinoff company looking at quality metrics and endoscopy, but never taken a nickel, and it doesn't have any relationship to what we're talking about today. Thank you.
Thanks, Mike, and thanks for joining us so early. Mekalai?
Morning, everyone. My name is Mekalai Kumanan. I'm currently serving as the president of the Ontario College of Family Physicians and also the deputy chief of family medicine at the Cambridge Memorial Hospital. I do receive a stipend for both of those roles.
Thanks, and I'll be co-moderating the session with my colleague, Eleanor College. Eleanor?
Hi, Eleanor College. I'm a family doc in East Toronto and also the CPD program director for the Department of Family and Community Medicine. And other than an honorarium from the OCFP, I have nothing to declare.
And you can see there my declarations, some honoraria, as well as research and grant support, none of which I think pose a conflict for today's talk. So if just want to remind folks that if you have questions today, please do put them in the Q&A. And if you see someone else's question that is similar to something you want to ask and you really like it, please do put it in upvote rather than put in a new question. I'll be prioritizing the questions that have the most upvotes. So definitely give us a thumbs up if you want to see a question answered. If you want to just make a remark, a comment, put in some resources, network with others, then please do use the chat for that. It's wonderful to see everyone sharing resources there. Next slide. So without further ado, I'm really excited to get our session going. So I'm going to turn it over to you, Kieran, who's going to get us started. And then I'll just say that at 8:30, we'll turn it over to just after 8:30, we'll turn it over to Dr. Mike Kolber to talk to us about lipids. So we'll start with the long COVID, and then we'll move into our session on lipids.
Thanks, Tara. Good morning again, everyone. So as I mentioned, this is, I was asked to give an update, just sort of what do we know about long COVID now in 2024 from when I spoke about it at the same forum last year. And so I'm going to, some of these slides are just for references, and I think we're sharing the slides after, or at least the webinar is posted. So some of them I'll move through quickly and happy to really here to answer questions and try to provide some practical advice from what we know. Next slide, please. So I just think it's important to start with recognizing that the majority of Canadians have been infected with SARS-CoV-2, the virus that causes COVID, and a non-insignificant proportion of those individuals have developed persistent symptoms. And I think that's what a lot of you, and certainly I face in my daily practice in trying to help these individuals. Next slide, please. This is just a reminder of the definitions. There is still no globally accepted consensus definition, but the leading one comes from the World Health Organization, whereby people are continuing to suffer with persistent symptoms after a suspected or confirmed COVID-19 infection. Those occur 3 months after that infection, and the duration of those persistent symptoms is at least 8 weeks and beyond. And that we're not explaining these by some alternative diagnosis like iron deficiency anemia or heart failure, for example. Next slide, please. This is what I think is the most important slide to highlight what we know and how much things have changed in 2023. So Statistics Canada and the Public Health Agency of Canada have conducted 3 cycles of surveys now related to COVID. This is the Canadian COVID-19 Antibody Survey. And in 2022, they finished their initial work around long COVID or post-COVID condition. And at that time, among Canadian adults, we had a prevalence of about 1.4 million or 4.6% of our population. When they finished the next cycle just this past summer in 2023, we saw that prevalence increase to about 6.8% of the adult population, or approximately 2.1 million adults in Canada. So that's almost a 50% increase in the prevalence of these persistent symptoms that people are reporting. Of those 4.6% in 2022, or now 6.8% or 2.1 million people in 2023, just under half, so about 42% of those individuals have symptoms that are persistent and go beyond 1 year. So that gives you a little bit of a flavor of what can we expect around recovery and prognosis of these persistent symptoms. And of those 2.1 million people, just under a quarter, so 22%, reported that the symptoms were severe enough to affect their daily life, whether that was getting to school if they were still studying or going to work. And so that they tried to estimate how many cumulative days of work or school were missed as a result of this, and it's about 14.5 million days of school or work. So that gives you a little bit of a sense of just how many adults are continuing to suffer with long COVID, how long that those symptoms can be expected to last for and recovery, and how severe those might be to affect somebody's daily life. Next slide, please. And one of the other questions they asked in this most recent cycle of the survey is, how are people getting care, and are there gaps in access and use of care for people with long COVID? So again, self-reported survey, but that the minority of Canadian adults actually went and saw a healthcare provider. So only 47% sought assistance or help with their symptoms. The family physicians and nurse practitioners, primary care remains the foundation of our healthcare system, and 83% of those individuals who did seek care sought care through their primary care providers. Unfortunately, the majority who reported that they felt they needed healthcare services didn't receive any treatment services or support. Now, why that occurs is unknown from this survey. Certainly, we don't have a lot of treatments to help with actually getting at the underlying issues with long COVID. So some of that may be simply coming to the researchers and to say we need to do more to discover new treatments. But this is what the survey showed, and I think it identifies some serious and concerning gaps in care for people who continue to suffer with long COVID. Next slide, please. Treatment is still being sorted out. This was an article that we published with as a Delphi process across a bunch of experts and people with lived experience, focusing on cardiovascular symptoms and sequelae. But I wanted to highlight the red box that is an acronym that stands for post-exertional symptom exacerbation, otherwise known as post-exertional malaise. Next slide, please. When you're thinking about seeing somebody with long COVID or suspected long COVID, and you're trying to think about how can I help them recover and restore their function, it's really important to ask them about symptoms of post-exertional malaise or symptom exacerbation. What does that mean? Well, it's quite simple. You simply ask somebody, if you exert yourself physically or cognitively, and it does not have to be a huge amount of energy. It can be something as simple as a stressful day at work, a stressful day at home, or even going for a walk. People will report that within 12 to 48 hours, they will have a crash where they are completely depleted from their energy. And often that crash can last several days or sometimes a couple of weeks. And so if you explore that subjective reporting of that phenomenon, it's quite common that people will have this post-exertional malaise. The estimates are approximately a third of, if not more, of all people with long COVID experience this phenomenon. And why is that important? Because if you prescribe physiotherapy and tell people push through it, you are, deconditioned, you can actually do harm. And you can lead to these profound crashes in individuals. And so we have to be really careful to first identify whether this is present in individuals, which will inform the type of physiotherapy or rehabilitation strategies and energy conservation strategies that we use. Next slide, please. This was a very fancy type of study that's called a Bayesian meta-analysis that my colleague Pavlos Bobos did. And basically, they looked at the effectiveness of treatment in a rehabilitation treatment context, exercise and mobility supports, across all the published literature. And what you see here is a forest plot just estimating the effects of that across different outcomes on the far left, whether that be respiratory function, people's quality of life, or subscales of their physical and mental health. What you see is that all the boxes are to the left of that dotted line in that far right column, meaning that they favor rehabilitation in general, and that rehabilitation generally improves various outcomes across the board. However, there was a potential signal of harm buried within all of that data, and they weren't able in this study to pull apart whether post-exertional malaise was present or not in the participants within these studies. But our strong suspicion is that that signal of harm, which is not statistically significant, as you can see in the bottom there, is likely related to some of those subpopulations of people who have post-exertional malaise. And therefore, when you push them through a rehab program, they get this substantial crash, and then their quality of life can actually be worsened as a result. So I just wanted to emphasize that, yes, rehabilitation is beneficial, but it always, just like every treatment, comes with risks of harm, particularly in certain subpopulations. Next slide, please. And so I wanted to highlight a physiotherapy clinic or set of clinics that are available in the GTA area, but also really virtually. They do a lot of work through virtual care. And I don't have any financial connection to Cornerstone. And Adam Brown has actually been a panelist on this forum before, and he runs Cornerstone Therapy. They're really doing some amazing work using biofeedback. So things like Fitbits and Apple Watches to monitor your resting heart rate, your heart rate variability, these various biological measures that can actually be used to guide someone's energy conservation and physiotherapy to avoid precipitating these crashes with post-exertional malaise. And Adam is a really passionate and intelligent guy, and he has an incredible team of physiotherapists. So I refer every patient that I have to Cornerstone. It is not covered by OHIP, so it is a private physiotherapy clinic. So full disclosure, people need to pay for it, or if they don't have private insurance, then it will come out of pocket. But I really think that Adam and his team is leading the way in how to rehabilitate people with long COVID. Next slide, please. There were some questions and definitely lots of interest around the country about treatments. We're still working on finding the evidence for which treatments work and don't work. But certainly low-dose naltrexone comes up a ton in the media and in the patients I see. The current evidence is very much lacking as to whether low-dose naltrexone works. And so the only publicly stated guideline comes from the Australian National Clinical Evidence Task Force. And their recommendations, which I agree with, is that we should not be using these medications outside of experimental, ethically approved, controlled trials. But people are continuing to ask and use it off-label, and that is a decision that yourself and your patients may need to make together. But my approach is generally to not use these treatments outside of ethically approved trials. Next slide, please. Lots of questions about prevention, both with Paxlovid and metformin. This, I think, is the best study observationally done that gives us an answer as to whether Paxlovid may or may not work, but I still think we need a trial. In this, they simulated a trial in this observational study, and basically when they were looking at health conditions that were a consequence or associated with COVID, that only the incidence of thromboembolic disease was reduced when you give people Paxlovid at the time of acute infection, and that those people were at elevated risk for adverse health outcomes to begin with. Next slide, please. The metformin question is, of course, very popular. This comes from the COVID out study. So what you're seeing here is a secondary analysis of a secondary outcome in the trial. The trial was not designed to answer this question, but this was an exploratory outcome that they looked at. And what they did find is that metformin was associated with a reduced risk of long COVID that was self-reported to be diagnosed by a physician. So in other words, there's a lot of problems with this study. And I worry that it's not ready for prime time, but the data in this exploratory analysis suggests that metformin might reduce the risk of long COVID. And again, that decision of whether to use it or not with your patients comes down to one of shared decision-making and discussing the risks and benefits. Next slide, please. A lot of individuals ask me, or patients need help with disability claims. And so I just wanted to give some pragmatic advice before I finish up here on how to do that. When I write letters and fill out forms for disability claims, and they're often in the appeal stages, first and foremost, I think as providers, we need to advocate that our patients have a diagnosis of long COVID, and we need to have the confidence to state that. There's been a lot of claims that have been denied because we've waffled on whether they may or may not have that condition, and then the insurance companies are using that to deny claims. The second is that they need to be identified as being disabled, and some policies will define that as being unable to perform at least 60% of their time at work. So I write that in my letters. They cannot do 60% of their work, and therefore should be considered disabled. Sometimes they're put through the paces with these various assessments by the insurance companies consulting providers, and they often are using assessment tools that are just not appropriate or validated in people with long COVID. And so, for example, they'll do functional tests and say everything is fine, but it's not fine, and they'll often precipitate a crash. So you can use something that's called the post-COVID functional scale, which is much more attuned to the function of people with long COVID. And you can rate the severity up to 4 on there as moderate to severely impaired, and use that to support your ascertainment that they are or are not disabled. And although we don't have any legislation or policy in Canada that states that long COVID is deemed a disability, to the south of us, surprisingly, they do. So next slide, please. So I've left this on here. I often include this, and you're free to quote this in your letters, that in the United States, under various sections and acts, it is deemed a disability. And so that often helps give some weight to our assessments that they are disabled and that they have long COVID. And here are other jurisdictions that recognize that, even if Canada hasn't passed this law yet. Next slide, please. So I'm just going to finish up with some hope on the horizon that there's a lot of research ongoing, both that I'm involved in and my colleagues across Canada as part of Long COVID Web. So the RECLAIM trial is actively enrolling. We've enrolled just over 150 people, I think now, looking at ibutylast and pentoxifylline to improve physical functioning in long COVID. The DEFEND trial, I'm leading, and we're just getting some funding to get it going. We're looking at asking the question, does Paxlovid actually reduce the prevalence and incidence of long COVID in people who are hospitalized and test positive but are not hypoxic, for example? So this is a common problem in our hospitals. Andrew Pinto at St. Michael's is leading the CAN Treat COVID trial, which is an outpatient trial looking at prevention of long COVID with Paxlovid. And in BC, our colleagues are leading a trial that actually is looking at answering the question about low-dose naltrexone as treatment. And again, that's where I think these types of treatments and use of these treatments should be kept for now. Next slide, please. We are actively developing multiple guidelines, 6 in total, of the post-COVID condition at the national level. And I sit on one of the co-chairs for this work. And we recently just published our good practice statements, the things that all clinicians should do for people with long COVID, on the website. So I encourage you to look there to help support your patients. Next slide, please. I wanted to remind you that we do have a diagnostic code. We're the only jurisdiction in Canada that has a specific diagnostic code for long COVID. It's 081. And I encourage you to use that, not only because it validates and helps support claims, it also helps people like myself with research when we're trying to do this at a population level. These are one of the ways in which we can study it. Next slide, please. These are some resources that myself and the team here has collated. They're there for you on the slides afterwards. Next slide, please. And there's a couple for patients down there at the bottom if you want to use those to provide to your patients. The links, the website links are all in there. You can go to the next slide. So in summary, post-COVID is common. We've seen it rise in prevalence as a result of ongoing infection, and it can be very disabling for a significant minority of individuals. Primary care remains the foundation, but I think that we need to call on our governments to develop a broader strategy as we see them divest in COVID and long COVID supports. We're leaving people without access or supports, including our providers, which need more help. A reminder to screen for that post-exertional malaise or symptom exacerbation as part of your assessments. And although there's a lot of promise about various pharmacological treatments, my practice, and I encourage people from a safety standpoint, is to use these in the setting of a trial. And hopefully some of those trials I've mentioned you can refer to and have your patients access if they're interested. Next slide, please. Just a thank you to a bunch of individuals here to acknowledge them. I won't go through them for the sake of time. Next slide, please. And I think, Tara, you wanted to speak to some other resources that we've presented here previously, which are very helpful, and I helped the ministry develop.
Yeah, thanks, Kieran, for a fantastic, really clear talk. We're going to break for some Q&A soon, but just to tell people, just remind people about these resources. The Ontario Health, a while ago released some guidance for post-COVID conditions, guidance specific for primary care. So just a reminder that that's a great reference. Next slide. I know we'll talk a little bit more, Kieran, about where our patients can get help, but e-consult is always a good option for us as primary care physicians, and there are still some specific post-COVID condition e-consults available. And then next slide, Kieran, you mentioned that you're a co-lead for Long COVID Web. This is really, I think, developing to be a repository of a lot of different information. And my understanding from you is that there will be a lot more kind of tools that are going to be being put on the website that are hopefully practically oriented for family doctors and others in primary care.
Absolutely. And Susan Law is the knowledge translation lead on the Long COVID web, and is really doing a phenomenal job putting together that library to help patients and providers. But it's still a work in progress, so hopefully more will come soon.
Thanks, Kieran. So why don't we end slides? And I just, again, want to thank you. I think you were very clear in providing us a picture of how many people have long COVID, how it's affecting their lives. What is it that we can do to support them? Where are the questions that we still have that aren't answered, and where we might be able to go for help. There are a few questions here that I'm going to start with. So one is really about resources for our patients. So somebody asked, I heard long COVID clinics are closing down. Is this true? Shouldn't we be opening more? There is no capacity in family medicine for this.
Yeah. Unfortunately, the answer to this question is in the world of anecdote. I use data as much as I can, but I haven't seen the data. I've only heard anecdotally from my colleagues who are running these clinics. As governments divest in COVID funding, so too these clinics don't have funding to stay open, and there are a lot closing in Ontario, BC. They've closed a bunch. So I think across the country, we need governments to invest in long COVID, not divest. And certainly, I think that's leaving our patients and us as providers in a little bit of a tight spot to support. Do more with less is kind of what we're continuing to be asked to do. So I hope that there'll be more of a provincial strategy coming down the pipeline, but I haven't seen or heard about that of late. And that's on our government officials to step up to the plate for that one.
Yeah, let's hope. There are also some questions, a question here, about metformin. Now, I think you answered that in your talk. And just to clarify, it sounds like your view is that we shouldn't be prescribing metformin for prevention of long COVID.
It's a tough decision that you need to make with your patients on an individual level. My bias as an internist is I deal with medicine complications, pharmacology complications in hospital like every day, and so that's my bias that I bring to the table, and I don't want to do harm, especially if I'm not certain that there's any benefits. And the data right now for metformin suggests to me that there's a promising signal, but we don't know that there are true benefits. And time again, we've seen promising signals and then studied them properly, and nothing comes of it. There is no benefit. So I just don't like exposing my patients to harm where there's no certainty of any benefit. If you are interested, the COVID Out trial, which is the one that was published in Lancet, is being referenced here. They use 500 milligrams as a starting dose for metformin, and they up titrate to 1,500 milligrams a day. It's 500 in the morning and 1,000 in the evening by day 6, with a total treatment duration of 14 days. And remember that trial was for treatment of acute COVID. That's where they designed it. And then they did this secondary analysis of this secondary outcome, and they thought they found some benefit. So again, metformin is relatively low risk as a medication, but there are still risks. And it's a decision and discussion you should have with your patients and make that shared decision together if you choose to use it off label in this case.
Thank you for that insight. So another physician's asked, what percentage of those with disabling long COVID have a pre-existing mental health diagnosis compared with the general population?
Yeah, it's a tough one. Because the population studies have been really skewed. They've been very challenging to figure out exactly the truth behind that question. Certainly that there is some studies have suggested that a pre-existing diagnosis of a mental health condition like depression or anxiety puts you at risk for long COVID. But again, it's not borne out that it is identified as an independent risk factor. And then you have the sort of the stew that comes up where people are grieving at the loss of their independence as a consequence of their long COVID, And that sometimes is conflated as depression, and maybe that explains everything with their long COVID. And I don't think that's true. They're going through a state of grief because they've lost everything, their jobs, they can't look after their families. So the short answer is there is no definitive data where I can say 20% or whatever percentage of people have these pre-existing mental health conditions. But I think we need to be very careful to try to attribute their symptoms to a primarily mental health disorder and look underneath the hood for other causes.
Thanks, Kieran. So there are a few questions here about long COVID and vaccination. So one of the questions is that long COVID is long COVID less in currently vaccinated patients versus non-vaccinated patients, or patients who got the vaccine more than 1 year ago?
Yeah, that's a really important question. Thanks for asking. The data, again, is always somewhat confusing and limited, but the best data that we have across the world from various countries is that vaccination protects against the development of long COVID, probably through the fact that you get less severe disease, which is identified as a risk factor for long COVID when you're vaccinated versus not. The trouble is you have lots of natural immunity through infection circulating. As we said, 73% of Canadians have been infected. So there's protection there as well. There's also a question of whether the variants are less severe over time and therefore are less likely to cause long COVID. But if you try to boil that down to the best data we have in 2024, vaccination before you're infected suggests that it will be protective against long COVID. Vaccination even after you're infected but have not developed long COVID suggested to be protective against development of long COVID. Less clear if you have long COVID and you're vaccinated, if it protects you from getting worse long COVID when you get reinfected. But hopefully we'll have some more data coming on that in the near future as people are experiencing their second, third, fourth, fifth infection. And that's, I still strongly recommend vaccinations across all of my patients, including those with long COVID, because I do believe it works.
That's helpful. I mean, I think there's some also questions saying, I've had 4 or 5 patients getting COVID now after the new vaccine, 4 to 8 weeks after that. Is the new vaccine still helpful? There's also a question saying, long COVIDs, I've had some patients get long COVID symptoms post-vaccine. Have you ever heard of something like that? I don't know if you want to comment on.
I can comment on both, yeah. So just reminder, vaccination does not prevent infection. It prevents developing severe infection. The preventing infection is through the other means, hand hygiene, masking, all of those other things that we've talked about in previous webinars. But vaccination just simply reduces the risk that you get severe disease. That's where its primary efficacy comes to bear. And in doing so, we think that's how it's connected to prevention of long COVID. But there may be other mechanisms we discover in the future about why it may be protective. There is no data to suggest that vaccination makes long COVID worse. Sometimes there's the effort that they go to get their vaccine, plus the initial sort of mild adverse effects of the vaccine can trigger a post-exertional malaise in those who suffer with it. So they might have a couple of weeks where they say, oh, the vaccine made everything worse for me, but then they recover after that. And it's sometimes you just have to support them and validate them through that. The bottom line, though, is there's no data that's demonstrated that vaccination makes long COVID worse or is putting you at risk for developing long COVID.
Thank you. I think there are now a couple of questions I had that have been asked kind of about the physiology behind it. So somebody's asked, what is the putative cellular biochemical etiology of COVID? I've read about COVID causing lasting damage to body systems like the neurologic system or cardiovascular respiratory system. Is long COVID due to this damage?
Yeah, it's a great question. I took the slide out because it just takes too much time to walk through the mechanisms. But the short answer is we don't actually know the underlying biology or pathophysiology. There's about 5 different proposed mechanisms with persistent inflammation, viral reservoirs where the pieces of the virus or the virus itself sort of hides in the gut and causes long-term sequelae. There's direct damage at the time of the acute infection. So, for example, you get lung fibrosis and you have persistent shortness of breath as a result of that. Then there's some theories about gut dysbiosis. So these sort of autoimmune and bacteria that live in our guts are misbehaving, for lack of a better word, as a result of infection. And then there's autoimmunity. And some people suggest that there might be this phenomenon called microclotting, which is still highly controversial. The bottom line is we're not actually, we think that there may be more than one subtype of long COVID. Just like there's many different types of cancer, there may not be just one long COVID. There's different phenotypes of long COVID, which we think might be connected to different underlying mechanisms that's driving it. We haven't figured it out enough to be definitive and say, this is 1, this is 2, this is 3. But there's been a lot of interesting work in the last year that's tried to help understand that a bit more. And the trials that we're doing now are targeting some of those individual mechanisms. So if there's positive trial findings that come from that, it might lend some more support to saying that this is one underlying mechanism because this drug addressed that and things got better.
Thanks, Kieran. So you drew an analogy between long COVID and cancer. Somebody asked, I heard COVID has oncogenic genes similar to Hep B, HIV, HPV causing cancer, or EBV causing MS. Can we expect the same in 10 to 20 years that COVID might cause cancer?
Yeah, I'll say I certainly hope not. But long COVID's only been around now for a couple of years, so we don't have studies that can follow people for 10 to 20 years to find out if that's true. There might be these theoretical risks, and we draw on our experiences from other viral infections to suggest it, but that will ultimately require long-term studies to determine if that's actually a true thing or not. And all I can say is I hope it's not going to be true in 10 years.
And then the last kind of question I'll ask is again about physiology. So what is the reasonable physiological explanation for post-exertional malaise? Is it affecting mitochondrial functioning? And will exercise cause lasting harm if the patient does push themselves? For example, many former athletes are used to pushing through to pain. And I will just say, when you were speaking, I think myself, I was trying to figure out, okay, is it just through history that I would be able to identify someone has post-exertional syndrome, or is there something else there?
Yeah, for now, the diagnosis in quotation marks of post-exertional malaise is a subjective or a clinical one in those characteristic descriptions that I just described to you earlier. There is work in the long COVID web that are and in the other research realms that are trying to identify a validated tool or diagnostic approach to truly saying you have post-exertional malaise or not. But for now, it's in the realm of a clinical diagnosis, and we don't know the accuracy of that. But certainly, it's helpful when the patients that I speak to kind of adhere to that energy conservation. As far as the pathophysiology, there was a really interesting study that came out a few weeks ago in Nature that looked at a cohort of individuals and did some muscle and mitochondrial and VO2 uptake testing. It suggests that people with post-exertional malaise have an inability to utilize the oxygen that goes right down to the mitochondrial level, and that it probably reflects what we see clinically. So we're making big steps, I think, in understanding this phenomenon that's been around for a long time. It's associated with, in fact, it's one of the diagnostic criteria for ME/CFS. So I think we're going to we'll move the mark on the needle when it comes to understanding and hopefully treatments. The last point was about long-lasting effects. There's no data to suggest you can do permanent damage, but certainly the crashes are quite profound and disabling for people. So we try to avoid them at all costs. And that's where I mentioned this cornerstone and heart rate monitoring is really pushing the envelope in trying to give people an objective method or measure to guide that energy conservation and rehabilitation. Because if you push them too hard or they push themselves too hard, they'll experience that crash.
Thank you so much, Kiran. You did a fantastic job sharing so much new cutting edge information in a very vast topic. Just want to let everyone know that Kieran's recording of Kieran's talk will be available on our website. People have also asked if the slides will be available. Yes, the slides will be posted on our website. Kieran, we've gone through a lot of questions, but there are a few more in the Q&A. So maybe if you're able to take a look at those and answer them, that would be great. I know people are also making a few comments in the chat about different treatments and studies. I did want to also point out to folks, as we're transitioning, that Dr. Dan Washevsky joined us for the first 30 minutes. I forgot to mention that. Thank you belatedly to Dan for doing that. And he did actually answer some questions in the Q&A. So if you go to the answer section, you'll see some of that. I did want to actually flag one of them because there was questions about Paxlovid and being able to get Paxlovid prescription in advance of travel. And I think every time we have a COP, this comes up. So he did answer the question, and it basically, the bottom line is at this point, we're unlikely to see a change to prescribing Paxlovid in advance until there is clarity and coverage, because the federal supply of Paxlovid expires in the spring and provinces will have to either purchase their own or use other methods to cover it. So take a look at his full answer in the Q&A. All right, well, thanks again, Kieran. We'll have you go to the Q&A and then we'll come back to you if we have time at the end of the session. I wondered, Olivia, if you can bring up the slides, and we'll turn it over to Mekalai, who I think wanted to give a big an update. We know today is going to be a day for a big announcement. I heard that on the news this morning myself. And so Mekalai, I know you wanted to speak to that. Olivia, just to let you know, we're seeing kind of speaker notes here, so hopefully you can just show us the slide expansion of interprofessional primary care teams.
Thanks, Tara. Maybe I'll just get started. And you're right, there was the announcement yesterday that we'd get more information today about the federal health transfer. What I wanted to touch on today was the announcement that came out last week from our provincial government for $110 million invested into team-based care. So you've probably seen that at the Ontario College of Family Physicians, we have been leading calls with our partners to expand team-based care across the province for all patients and family physicians, regardless of your payment model. And you may recall that last year, our provincial government had announced an expression of interest process that I know many of you put applications in for, and that was specifically for that funding. At that time, the government had made a commitment for $30 million to support 18 new and expanded teams. What we understand from that process is that it garnered more than 300 proposals. And so last week, the government announced that it would actually triple that investment and increase it up to $90 million to support the expansion of 78 new teams, new and expanded teams. And they also invested another $20 million to support existing teams to help meet their operational costs. I will just say, for those of you who may have been part of an expression of interest, you may be wondering kind of where that stands. I think some communities have heard. We understand that the government is in the process of communicating with successful applicants, and ultimately all applicants will be informed. And I would like to say, I think this is a really positive step forward. And I think it's important to acknowledge that I know we're facing so many other issues in family medicine that still need to be addressed. We won't stop advocating at the OCFP. We'll continue to push for expanded team-based care across the province. We'll continue to work on addressing the administrative burden that we know that we face in primary care. And we also are hearing from many of you and have shared with government concerns around compensation, really not keeping up with inflationary pressures and really not being reflective of the complexity of care that we are managing in family medicine. So keep your eyes peeled, because we'll continue to work on those areas.
Thanks so much, Mekalai. Thanks for your advocacy. And I see some comments in the chat just, about family doctors being important parts of those teams, and us needing to ensure to have that message heard. I'm going to turn it over now to my colleague, Eleanor College, who's going to be moderating the second half of this session. A reminder that we'll have the formal didactic component completed by 9 o'clock, but we'll continue till 9:15 to take people's questions. So over to you, Eleanor.
Thanks, Tara. And I just wanted to welcome and introduce Dr. Kolber, who's going to get us started talking about the simplified lipid guideline.
Thanks, Eleanor and team. Happy to be here. It's funny, every province is dealing with the same stuff. Family docs, middle, pushed out. If you want to see us be pushed out, come to Alberta. That's recruitment. Anyways, super happy to talk about our peer simplified lipid guideline, which we published last year. 3 years of hard work, and I'll try and cover it in about 15 minutes. Next slide, please. So for those that don't know the peer team, we're kind of a grassroots organization that started in Edmonton and kind of across Canada. And we have some basic tenets when we're doing guidelines. Our guidelines, we really believe, should be by primary care, for primary care. They need to be evidence-based and high quality evidence. So as Kieran said, looking at COVID-related treatments, that needs to be a randomized control trial. So we look at the highest level evidence. We really value patient-oriented outcomes and not surrogate markers. And obviously that's super important in a lipid guideline. Medicine doesn't need to be more complicated. So in any case, we have a choice of being more complex or simple. We try and find a simple answer. This guideline focuses on primary prevention, but also, because that's our wheelhouse, but also secondary prevention. So we give advice on both. Shared decision-making is really a basic tenet. We really believe patients need to be involved in the decision makings which affect them. We use GRADE, as everybody uses GRADE. Those that use GRADE go, God, it's not as easy as you think. Anyways, Institute of Medicine tenets also thou shalt, and one of the most important tenets are thou shalt not have financial conflicts of interest, and nobody in the scientific or guideline panel has a industry related conflict of interest. And really important, we separated our evidence team from our guideline panel. And we have two major publications from this: the systematic review that looked at all of the meds and everything, and then the guideline recommendations. Finally, we included and introduced the concept of time needed to treat, guidelines that continue to ask more of family physicians. Just do more and more and more. Like Kieran said, more with less is really not sustainable and not palatable. So we actually did a general but not formal assessment of, well, how much time would this look at it? And in one of our guideline panel members was a patient, and it's not just our time, it's the patient's time as well, which is really important. So the concept of time needed to treat needs to permeate probably all of the guidelines going forward. Next slide, please. So how do you update? And while I was involved, I did not chair the 2015 guideline. Mike Allen did, and shout out to him for the initial start. What we did is we looked at the 2015 guideline. We knew that some of the stuff hasn't changed. Some of the information evidence hasn't changed. We carried for a few recommendations. What did change is classes of medications. So there are now expanded medications, whether it be since 2015 ezetimibe, icosapent, and PCSK9. So, and we actually weren't sure what an omega-3 was. So we actually had to split the omega-3s into two. And so we had fulsome systematic reviews for the medications. And then our guideline panel actually had, well, what about statin intolerance? Had some questions. What about older adults? And so we had 10 additional questions, of which we did a rapid review of the evidence, and voila, you pull the handle and you get a guideline. It's not that easy. Again, 3 years. Next slide, please. So we're really cutting to the chase here with the time, and so I'll just go forward. We do recognize, and the literature shows that we seem to be lipid focused, and we recognize that lipid is only one of the risk factors for cardiovascular risk. We know that lipid levels do not change systemically change in an individual over the time frame. We know there's lots of biological and analytical variability, which is greater than the actual probably true change. And so similar to all other guidelines that have actually looked at frequency of lipid testing, we are really trying to get away from the way we've been doing it for quite some time, where we're doing this very frequently and annual. So we actually suggested repeating lipid levels no more than, and maybe we can get to 10 years. Unless and with every lipid level that we do, we think we should be doing a cardiovascular risk assessment. So putting that patient into a decision aid and having a conversation about baseline risk and new risk with interventions. Once somebody's started, and statins are still king, you heard it here first, statins are still king. Once we've started lipid lowering therapy, and again, normally that's statins, we recommend against repeat lipid testing, and I'll show you why in a few slides. And then ancillary biomarkers, including LPA and ApoB, and CAC. CAC may have more evidence than adding LPA or ApoB to traditional risk factors. And I'll show you too in the next slide. I think there should be a slide on that. Next slide, please. So this question always comes up. Well, the cardiologists wish to have us to do ApoB and LPA. And so when we look at cardiovascular risk, there's risk factors. And one of the ancillary supplemental questions was, what is the added benefit of adding these non-traditional risk factors to a traditional risk calculator? And so risk calculators are about 75% accurate. So if you look at area under the curve, a perfect predictive model would be 1. So we're about 75%, a little less when you get older, like over 75, it's about 60%. And so when you look at area under the curve changes, so we could add lots and lots of more risk factors, but does it appreciably change the ability to predict the risk of individuals? When we look at area under the curve changes, large changes should be about 10% or 0.1. Moderate should be about 5%, and you can go there on and so forth. And so when you look at the best evidence, adding lipoprotein A to a traditional risk factor, which includes obviously age, gender, diabetes, blood pressure, smoking, that kind of stuff, adding it improves the area under the curve of the risk calculator at best 0.004. Adding ApoB, about 0.02. And again, CAC probably might have a little more oomphy as far as improving the prediction of who will and who will not have an event in the future. And there's actually randomized control trials looking at standalone CAC versus traditional risk factors that are still ongoing. We do know that CAC has issues with affordability and access. But when you look at all of this stuff full stop, adding them adding a lipo-A and ApoB does not appreciably improve risk calculation for individuals. So I know there was a few questions on that initially. Maybe next slide. We could probably move on for time. We can go on to that more if you wish. So our guidelines, similar to 2015 and similar to other guideline bodies like veterans and U.S. Preventive Task Force, recommend against treating to target, but more target your treatment. Use a treatment that works and don't chase LDLs down the road. And this will kind of give you reasons why we came to that conclusion. And again, it didn't change from 2015. The most statin randomized control trials until just recently just use fixed dose statins called fire and forget, or just treatment, see what happens. When you look at large studies, we really should be seeing that attained LDL levels should correlate with lower coronary artery disease. And so it really should be like the mountains and the Rocky Mountains where they have this nice slope. And what it actually really is, the best fit line is kind of like the prairies in Saskatchewan. So when you look at the highest quality, large randomized control trials, the thought doesn't play out. Some randomized control trials don't even enroll for lipids. They can enroll in hypertension. As you know, Jupiter was based on a CRP level. Next slide, please. Again, we're not the first one, and so we know that this is different than what the Canadian Cardiovascular Society recommends. Other groups that have looked at this evidence come up with similar recommendations. Those that recommend treat to target, if you actually read the fine tune, they actually say, wow, they really do acknowledge the lack of evidence towards their recommendation. Canadian Cardiovascular Society says there really is no clear target to which LDL or ApoB level should be lowered, is clearly identified in RCTs. The Europeans say the same thing. We're really aware of the limitations. And so while they recommend it, they actually do acknowledge that there's lack of evidence to support it. Hitting targets not possible for many. So again, making it more challenging for us, more frustrating to us. And when you look at a systematic review, probably about 50% are not at LDL targets. And I've been doing this medicine thing for quite some time. Boy, when we were first starting targets, it was, we started at this level and this level, this level. I'm not sure. Maybe in 10 years, it'll be 0. It's just seems to be so incredibly low as these recommendations are getting to. The other thing is that I think the fundamental, really key piece is that lipids are only one piece of the puzzle. And wouldn't it be a shame to not treat somebody based on a normal lipid level, as opposed to taking somebody in its entirety and actually just saying, well, statins on average decrease the risk of a future MACE event by about 25%. Here's your risk. And why don't we just look at the whole patient, not just one piece of the patient? And the next slide, please. And probably very interesting is that the team that looked at this question, treat to target or target treatment, actually, and the recommendation from the panel was we were not going to recommend treating to target. And lo and behold, right after the month or two after, a randomized control trial, the first one that actually looked at this. So Lodestar in Korea, in secondary prevention, randomized about 4,000 patients to treat to an LDL target versus just going on a moderate to high potency statin and then follow them for 3 years. At 3 years, MACE was the same, mortality was the same. The conclusion from the authors were treat to target works better than just fixed dose statin. Our conclusion on that is that there is no difference between fixed dose and treating to target. Love to see that in North American study, and then hopefully that would be the end of all this work to try and treat to an LDL. And finally, in the spirit of simplification, less ongoing testing, less repeat stuff, and then less temptation to escalate and use medications that maybe have less evidence. So that's kind of our we think it is an alternative way of looking at caring for our patients, and a simplified approach, which does not cause harm, but is much simpler to fire and forget, and not treat to target, but target your treatment. Next slide, please. Boy, I sound like I'm on a soapbox. Boy, oh boy. Okay, so what did we do for the systematic reviews? Oh my goodness. So we did 8 systematic reviews of systematic reviews. Oh my goodness, it was a lot of work. 76 systematic reviews. There were no systematic reviews on bile acid sequestrants. There was only a systematic review on harm, not efficacy. We looked at both efficacy and harms of all of these groups. And again, we weren't sure what an omega-3 was, so we had to split EPA off alone. Wouldn't you know that? Wow, look at that. Looks like a lot of evidence on PCSK9 inhibitors. 26 systematic reviews. If I told you there was only 2 large randomized control trials, I think your shoulders would shrug. And I think next guideline, we're actually going to go with systematic reviews of randomized control trials, because by just repeating the same systematic review and the same data, it makes it look like this data is really robust. Where it is robust is statins, and there's 30 systematic reviews on almost 200,000 patients. Next slide, please. So cutting to the chase. So this is combining primary and secondary prevention, and the blue is statistically significant medium relative risk. So you could read that by saying ezetimibe has a 7% relative risk reduction, and it was significant in 3 out of 3 systematic reviews. And so you can see ezetimibe might have some benefit for MACE. That's major adverse cardiovascular events, and we tried to use a 3-point MACE when able. So it looks like ezetimibe might be beneficial for MACE, fibrates, EPA alone, and PCSK9s. And then if you look at statins have about a 25% relative risk reduction, and statins are the only medication in primary and secondary prevention that actually changes all-cause mortality by about 10%. If you look at primary care alone, which was our focus, again, we did look at secondary, but primary care alone, statins are the only one. Next slide, please. And next slide. And that's the primary prevention. So all of those other ezetimibe, PSKs, there's only evidence really for secondary prevention. So primary, statins are still king. Okay, next slide, please. So what did we recommend? We recommend, again, if you're going to do a lipid level, please consider doing a cardiovascular risk assessment, which we didn't talk about initially. Is we believe that you can start doing your risk assessments at 40 for males and at 50 for females. You can do it earlier if you wish. So when you do a risk assessment, which at that time might include a lipid level, and should include a lipid level initially, those that have a 10-year estimated risk of greater than 20%, we recommend discuss statins. And from 2015, we put in the caveat, maybe we consider high intensity statins. And again, in the top there, and in our summary, we give some dose suggestions for moderate and high and low. For a 10-year cardiovascular risk of 10 to 19%, we suggested discussing statins, again, the potential benefits and potential harms with a shared decision tool. And for primary prevention, we recommended against all non-statin drugs, either in by itself or in combination. The evidence is not there. For secondary prevention, statins work, and statins are king. So recommend, discuss, and encourage high-intensity statin. And then we said for those that require or wish for additional cardiovascular risk reduction, we recommend discussing ezetimibe or PCSK9s. Due to potential harms, and actually I wrote the tools for practice on icosapent when it first came out, and I think we missed potential harm. So atrial fibrillation was about a 1.5% absolute risk increase, and major bleeding was about a 1 in 200. And we kind of, I think we skimmed over that, and so we actually downgraded icosapent to come after ezetimibe or PCSK9s. Next slide, please. So bringing it all together, most people don't read the whole guideline, but maybe they could read the 2-page summary. So the 2-page summary basically walks you through primary and secondary prevention on the top there. You can just start clicking on the side boxes, please. Yeah, there you go. So it tells you who to screen and when. Everybody still gets lifestyle. So physical activity and Mediterranean diet. Mediterranean diet is well rooted in the evidence, both primary and secondary prevention. So everybody gets that. Everybody gets risk estimated. And again, we decided to still have 3 pillars: risk under 10%, which we just say healthy lifestyle, and re-estimate in 5 to 10 years, or sooner if things change. 10 to 19%, as we said, offer a moderately potent statin. Greater than 20% offer a high potency statin. And then once on it, no repeat lipid testings and no CKs or ALTs unless clinically indicated. And again, we have a little a table on what low, moderate, and high potency statins might look like. On the second page, next slide, please. We have some prescribing considerations about potential benefits, some adverse events to look at, some costs, obviously important on things like PCSK9s, and this is basic evidence. We also, our team looked at statin intolerance, and it's remarkable. All of the research that goes on in society, and there's not a lot on statin intolerant people. Are they really different? And what we did is we gave you some options. We said maybe we could consider a lower dose, alternate daily doses, different statin, that kind of stuff. And then finally, we have some frequently asked questions, including some QR codes. So QR codes to our decision aid, some Mediterranean diet, and an RX files exercise prescription. So in summary, for the 2023 lipid guideline, next slide, please. If you're going to do a lipid measurement, we recommend that you do a cardiovascular risk assessment because it's the person, not the lab test, that's the most important. We recommend lifestyle for all. And again, encourage you to use some physical activity, either prescription or link. Mediterranean diet, we use the veterans link, which was excellent. Good evidence. We recommend targeting your treatments, not treating to targets. For secondary prevention, ezetimibe and PCSK9s if you really wish for additional risk reduction. And we didn't talk about older adults, and I'll skip that probably for the question and answer. And finally, shared decision making. We really think it's important to have a tool to start the discussion about here's your risk, here's baseline risk, here's your new risk with certain interventions, which include non-pharmacological and pharmacological. And so happy to show you the decision aid if people wish. So thank you for your time. That's a lot of stuff in, I'm not sure how long it was, but happy for questions, and I suspect there's lots of questions.
Great. Thanks so much, Mike, for bringing some guidelines and also just thinking about how we do implement them in family practice and the time that it does take with patients. There are lots of questions. Just starting with one of the top ones here is the idea of not treating to an LDL target true for diabetic folks as well?
Yes. Yeah, we'll just go. There'll be so many questions. Yes, the premise can hold true for the diabetic folks as well. Absolutely. We believe the tenets, and we believe the evidence does support it's non-inferior and quite a bit simpler. And so, yes, all full stop. All this busy work, for minimal to no benefit, we say fire and forget. And really happy that we made that recommendation, and the Lodestar comes out to just reaffirms it, like the first randomized control trial, and yet there's still a lot of resistance to, well, I've been doing it for 25 years, or specialists are telling us to try and get to a target, that's for sure. So yeah, there's still a lot of work to be done, but yeah, absolutely.
Great. Well, and I think along those lines, one of the other questions that comes up is just regarding the messaging. Patients are going to be confused when they get one message from their cardiologist and another one from us. So just wondering how you address that in your own practice and your thoughts around that.
Well, I practice in Peace River. There are no specialists, so that's easy. Come on up to Peace River, and we'll happily take anybody that has a pulse and a no, just kidding. So, you know, I'm not naive enough to think that patients get caught in the middle. I think having a conversation with the patients and saying, you know, I guess twofold. Number one, we are the experts for primary prevention. They shouldn't be seeing specialists. So, hey, you know, I'm confident in that the way we're going down the road, this is supported in evidence. And how do you feel about this? The second thing I say, the patient in front of you, having that conversation, if you do the right thing for the patient, have the discussion and make a decision, that's totally fine too. And just know that there are areas that maybe certain groups might disagree upon, and everybody probably has their own way. This is probably not the first time that they're caught in the middle between conflicting, and I think we need to do what's right for our patients. And I think what's right for our patients is simplify things, not continue to go to labs and doing all this other stuff. And I think we will still, I'm confident that we'll see similar outcomes if the Lodestar trial is repeated. And everybody's got their unique relationships with their specialty colleagues.
Great, thanks for that insight. I'm also wondering, a lot of questions around targets, because this is, I think, quite a big change for some. Not treating targets, lipid to targets applies to both primary and secondary prevention, or just a primary?
You know what? So we focused on primary, but again, secondary prevention, Lodestar was secondary prevention. So people are going to say, well, what we did leave out is we weren't prescriptive as to who you may wish to consider additional risk management. So who do you consider ezetimibe or PCSK9s? And so we could probably, while we didn't prescribe it in the guidelines, I think it'd probably be reasonable to follow something like the veterans. The veterans said somebody with a recent, recurrent, or disease with ongoing risk factors, ongoing smoking and that kind of stuff. The evidence, and again, we were a step away from the randomized control trials. The evidence on ezetimibe is most of it's from one secondary prevention randomized control trial added to statins, which was extended because they weren't going to stop for fertility twice. So if you really think that's the evidence and strongly believe that that's the truth, that 7%, or you go, gosh, they just continued to do the study until they actually found what they were happening and closed it. PCSK9, the evidence on PCSK9 is actually held into question as well at the randomized control level as well. So we would say probably the best benefit is statin, and then a higher dose statin compared to a moderate potency statin is probably better than ancillary or adding additional medications, if that makes sense. Did I answer that question, or was that too circuitous?
I think it's obvious that there's lots of trials out there, and it's hard to interpret them all. I think actually maybe answering this other question, which is along the same lines about when should people be on medications beyond statins? Laura was wondering, she's reading that the lowest LDL is best even under 2. So if someone is on max statins at highest risk, how would they know if they should go on a PCSK9 or, for example, to further lower their LDL?
Yeah, it just comes back to you have to be confident and not continue to chase something that's less meaningful than actually choosing a medicine that actually changes MACEs and cardiovascular outcomes. And so I would say be confident that we don't have to do this and don't have to continue to chase and chase and chase. Your patients, I think, will have the same outcomes. And again, all of these other added benefits. We think this is the best available evidence, and we offer an alternative approach. And I think we have to get away from thou shalt and thou must. We said for our guideline, just to simplify it, no, for primary prevention, no, we don't recommend ending non-statin medications. There's no evidence. And so all we're talking about now is secondary prevention, which obviously are higher risk. But again, the evidence doesn't support this treating to this low LDL. So we have a lot of work to do, and to be busy on this. This might be sounding a little bit of soapbox. I think we need to be confident that we can just target our treatments and let it ride. I know it's hard because we've been doing the same thing for 25 years. The cardiologists also recognize that they've been teaching this way for 25 years and also probably need to revisit what they're actually teaching as well. So be confident what you know. And if I had a longer time, we could show you more. But be confident that this is a reasonable approach for your patients.
Yeah, and I think that a question along the lines of the targets and being confident, and I think you did answer this live, is how do you know what dose of statin to use if we don't test for the effect? And I believe you talked about the moderate and high intensity, but perhaps we could just go over that again for those
Yes,
that
of
didn't
course.
hear.
Yeah, of course. So I would say, moderate potency statins, and that'd be something like atorvastatin 10 to 20 or rosuvastatin 5 to 10. And again, just be confident that interventions work irrespective. So the studies also show interventions work irrespective of changing the LDL. So maybe I should have also highlighted that again. And number two, so putting somebody in a moderate potency statin would decrease their relative risk of a MACE by 25%. And if you go from the moderate to a high potency statin, it probably adds an additional 10% relative benefit, or up to 35%. And so I mean, I'm comfortable doing this. I think we all need to be comfortable just saying, hey, here's your statin, here's your baseline risk, here's your new risk, and let's just see how things go. And without continuing to chase. So I would say for my practice, I choose moderate and just leave it in the middle. I'm a middle guy.
Excellent. I'm wondering, just in the interest of time, I did want to give us an opportunity to just briefly talk about the patient decision aid. Because you
sure.
have a shared decision aid, so maybe we could just bring that up quickly just to show folks if they want to use that in the office. And while we're bringing up that slide, question, should liver enzymes be checked 2 months after starting statins?
No, that's old school. That's what we were doing 25 years ago. So statins are safe in people with liver disease, and most of our liver patients, those that are not end stage and requiring transplants, die of other things. And so we do not need to do baseline and or repeat unless clinically indicated. And obviously there's always a caveat. The risk of fulminant liver failure from a statin is about 1 in 200,000. So yeah, we've gone away from routinely doing CKs and ALTs, which I was doing when I was starting 25 years ago. So we've come full circle. It's good.
Yeah, and actually along the line, someone asked about CKs. If a patient develops myalgias on a statin, should you check a CK in that situation?
Yeah, it's tricky. So it's tricky. Statin intolerance is a challenging area. Best evidence shows that for all people that are in a statin trial, and we'll talk about placebo versus an active ingredient, in the first year, statin related myalgias are about 15% in the statin and about 14% in placebo. So 1% absolute difference. So it's quite, for all those that feel that they might have a statin induced myalgia, probably only about a 1% absolute risk increase in the first year, and afterwards it's not there. Whether or not you order a CK is really up to you. I think obviously I'm not, there's very rare cases of rhabdo and weird things with statins as well. So I think that would depend on clinical indication. We actually recommended, maybe having a conversation with your patients, maybe stopping and then re-challenging or restarting after you've had a discussion about the potential benefits and potential harms and seeing how that goes. But that is a challenging conversation for sure. Great question.
Excellent. Another question from Lee, which risk assessment tool is best?
Well, that leads into our risk assessment tool. So if you want to pop that risk assessment tool up, that would be great. And I could just walk the people through it.
Sure. Can we bring up that slide, Olivia, with the patient decision aid on it?
So we've had we used to be on BS medicine. Now it's decision aid. It's we get refined. So this is 2.0. This is maybe I'll just clarify a couple things. So on the left-hand side, you can choose where you live. In Canada, we have Framingham, which is the model, that's been validated in Canadians. There's also the pooled cohort equation, and that's the Americans. It's important that you know what you're actually estimating, and so you'll know that Framingham and PCE is a bit different. So if you have Framingham, which is clicked up there, you can see your 10-year risk of cardiovascular disease, which includes heart attack, angina, failure, stroke, or intermittent claudication, and pooled cohort would be a little tighter. So you put everything in there. So your age, your sex, smoke, you guys have seen this before. And then you get your baseline risk. So this is the starting point for a patient. And you can see that the lipids come into it at the bottom there. And then next slide, please. You can actually use this to have a conversation. So we say, okay, I'm going to try Mediterranean diet and physical activity. So in our decision aid 2.0, you can choose more than one option. So the problem with the old one was you can only choose one by itself. So now you can choose more than one option, including lifestyle and non-lifestyle or medication. So if this was me, so if I was going to do Mediterranean and physical activity, you can see my baseline risk went from about 14% to about 7% with those two interventions. Next slide, please. You could also say, okay, well, I'm just gonna, I don't want to do any of that stuff. What would it look like if I took a low to moderate dose statin? And then you can see your new risk here. The final, next slide, please. The final piece of all this, and again, I'm quickly going through this, is that you can see that if you choose an option for primary, again, this is only for primary prevention. We don't risk estimate secondary prevention. So for primary prevention, if we choose something that doesn't have really, is not grounded in evidence in primary prevention, like ezetimibe, PSKs, and fibrates, you're going to get a little warning thing at the bottom say it really has minimal evidence in primary prevention. So we think that we've refined the tool. We're really happy with how it works, and it seems like lots of people seem to be using it. I think we get a something like 1,000 a day on this site throughout Canada. So we encourage you to go after it. And the really cool thing is if you click on EMR note share link, it'll say we had a conversation, the baseline risk was this, the new risk after discussing this was this, and you can actually copy and paste it into your EMR, and it's really fun to do that. So I actually use this in my practice. So it's the decisionaid.ca, I believe, if you go back to that first slide. But we think that this is a great start. It's a ballpark. All of these tools are ballparking, and it's just to open the conversation.
That's great, and we'll make sure that we include this in our resources that we send out after our session today. Very quick last question. I think you did answer this. Suggestion for a handout for patients for the Mediterranean diet. I believe that's on your guideline. Is that
Absolutely
correct?
is. Yeah, you know what? That's great. We also have a patient handout, and so you can actually QR code that Mediterranean diet, and super easy and super helpful there. And so we actually encourage people to give their patients this handout as well. Sorry, I didn't get a time to chat about that.
No worries. Thanks very much, Mike. We won't be able to answer all the rest of the questions because we're running out of time, but thank you for bringing us these new guidelines, and look forward to using the tools and resources to put them into place in our practices. And can we just move to the next slide? So this is a very quick, well, not a quick reminder, but a reminder for those that live in Toronto that there are options for COVID vaccines now through the Toronto Public Health Community Vaccine Clinics. And next slide. And there also now we have a PDF with maps of pharmacies in the Toronto region that may be providing this COVID vaccine for pediatrics, but we do ask you to call and check with them first because this list was assembled at the end of December. Next slide. A reminder too, if you have questions about the COVID-19 therapeutics, the support line. Next slide. Recent sessions that you can check out on our website. Next slide. And also how you can access them. Next slide. And then I'm going to just turn it over to Tara in a moment, but I did want to say a big thank you to her for her amazing energy and determination over the last 4 years. I think she's moderated at least 60 sessions, which is amazing. And she's kept us as family physicians up to date. She's asked difficult questions at times when we needed to advocate for ourselves. And she's really sort of pushed the envelope in making sure that we can stay up to date with our practices and help our patients. And I'm going to turn it over to her now. Thanks, Tara.
Thanks so much for those kind words, Eleanor. Yeah, it's hard to believe that we started this community of practice back in April 2020. And we didn't realize at the time what it would grow into and what a community, robust and vibrant community would grow into, and for how long we would be continuing. These have definitely been a highlight of my week ever since they've started. This is actually going to be my last session for the next while. I'm going to be taking a 1-year sabbatical starting March. And so this is my last session moderating. As Eleanor said, I think I have moderated about 60 plus sessions. So it feels momentous. So I do want to say as I wind up, a huge thank you to the team. I know us as moderators, we're there at the front of this session, but it's a huge group of people that really pull this together and make it happen. And that group has been a bit fluid over the few years with lots of different people who've been involved, but you can see their names here, folks from the OCFP, you know, shout out to Julia and Pavetra and Mina, who are currently supporting that from that end, and folks from the DFCM, Marissa, Aaron, and Olivia. And then, of course, we've got lots of other people who I'm not naming who are involved as well. Our co-hosts, my co-host Mekalai, who's been amazing to work with, and Ali Damji, our other co-moderator. I'm excited to leave this community of practice in with Eleanor and Ali and Mekalai and the team. Eleanor is going to be taking over as the co-chair of the planning committee together with Mekalai. And we really always look forward to your thoughts on how we can make these better. So if you go to the next slide, you'll just see that we are planning our next session for Friday, February 23rd. We're going to be actually having Liz Mugga from Ontario Health. So come with all of your kind of policy questions. And of course, we'll also have an ID doc giving an update on COVID-19. So really appreciate all of your support. And I'm going to miss joining as a host, but maybe I'll just join as an attendee over the next year sometimes. Thanks.